I wanted to present you with the speakers today. Martinus Richter is being delayed a little bit at the General Assembly, so he will speak afterwards. We will have Dr. Shadpur Demary, who is a radiologist from Johns Hopkins Hospital in the US in Baltimore. And thanks to him for flying over to give his talk. We will have Professor Ziegler, who is a professor at Drexel University in Philadelphia. And thank you also for flying over and giving your talk. We will have then Andy Goldberg, who is a foot and ankle surgeon in London. And thank you for giving this talk with us today. We also will have Chris Boots, who is a member of the EFAS board. He's the new General Secretary of EFAS, and he's been with us in the group since the beginning. And we've already got some ongoing research projects with him. So he will also come to give a talk, but later on, and I think he will also be delayed a little bit because of the General Assembly. I also want to thank Oliver Mikkelsen, who is also member of the board of EFAS, and he is also delayed. So we have to deal with this delaying thing. We also have Arnie Bursens, who is a member of the board and a secretary of the Weight-Bearing CT International Study Group. And he has been very active since the beginning. So first I would like to call Dr. Demary to present his speech. If we have time, then we can ask him a few questions, but the room is ours for the whole day. So if any of you guys want to stay over after, then we can still carry on speaking. And just before handing over the microphone, I want to thank our industrial partners. I think this is quite unique in the industry that three competing companies get together to support a research group to push forward new technology. So we really want to thank them warmly. So PlanMed, CareStream, and CurveBeam. And they've been supporting us since the beginning. And it's an ongoing process, but they will support us even more in the future. So thanks to them. And now handing over the mic to you, Shadpur.
Thank you very much. Just grab this slide. This is a slide?
Yeah. It's
great. Hello, everyone. So trying to get the next slide. Excellent. Thank you very much. Great, very well. So my name is Shadpur Demary. I'm from Baltimore. The topic of this 10-minute talk is looking at the role of advanced imaging in general of syndesmosis injuries and where we are now and what we can do with weight-bearing CT acquisition. So my disclosures, Giraffe Award, Career Development Award from 2014-2016, and I have had some industrial grant from Toshiba and CareStream over the last 4 or 5 years. Outlines. First, current imaging. You may not like it, the most established advanced imaging techniques right now for the syndesmosis injuries MRI. We're going to talk about a little bit of diagnostic performance of the MRI and MR arthrogram and see where we are right now, what is available as a routine clinical practice using advanced imaging for syndesmosis injury. The next step will be ongoing projects that we have at Johns Hopkins using a CareStream device. Doesn't matter, 3D dedicated extremity imaging device, which is basically determination of measurements, weight-bearing versus non-weight-bearing in symptomatic as well as asymptomatic subjects. That was the first line of efforts in terms of diagnostic evaluation. The second one was looking at the conventional measurements, automated measurements, as well as syndesmosis space 3D morphology analysis. These are the ongoing projects. I'll show you some very few examples in 10 minutes, and you see where we are going. And the last part, which is future directions, this is my most favorable part. It's a mission statement. Whenever I think I got lost among my projects, I go back to statement. I will reroute myself because that's what we want to get. And that's establishment of non-invasive 3D imaging with automated and validated measurements in subjects with syndesmotic injuries to accurately detect subtle biomechanical instabilities associated with acute symptoms, as well as future development of tibial talar osteoarthritis. So once we accomplish that, then we can establish fully this new technology as imagers. First part, MRI and MRA. Do they do well for diagnosis in syndesmosis injury? That was the effort of my great colleague and postdoc research fellow, Dr. Shakur, who is not here. I asked her to do a meta-analysis using all the available data, all of the diagnostic accuracy data in the literature, looking at the diagnostic accuracy of MRI and MRA for diagnosis of syndesmosis injury. We only found 7 studies, MRI studies, and this is demonstrating the forest plot of the diagnostic performance of different techniques, MRI, indirect MRA, and MRA. And these are the single study, each of them. And this points is the mean and the confidence interval of the sensitivity, sensitivities, and then specificity of each of these. So you can see they're all doing very well. These are the numbers, 8.89, 0.91. The only thing that is interesting is that direct MRA has lower specificity, which goes down to 0.067. But they are doing so well in terms of diagnostic accuracy. So there's not much of, also in sub-analysis or sensitivity analysis, we determined that there's not much of difference in terms of diagnostic accuracy when you're comparing 3T and 1.5 Tesla MRI. So we know for regular ankle imaging, we prefer 3 Tesla MRI, but for this particular question, it doesn't really matter. Available diagnostic studies in contrast in agents or gadolinium is really not necessary for this diagnosis. Actually, in the direct MRA, you actually decrease the specificity of diagnosis. And the main thing, so they're very good, they're accurate. Why we need to do a CBCT, why we need a weight-bearing imaging? Limitation, because they're not detecting associated biomechanical derangement. You may see some signal, but what's the actual mechanical or biomechanical significance of that? And that's where we can start looking at new technology, weight-bearing versus non-weight-bearing COMIB-CT. So the first attempt was looking at asymptomatic subjects. I had Delaram to look at all the previous papers looking at radiographic data or static CTs, and we came up with a whole atlas of different type measurements. I'm not going to go through the details because we don't have time. There's the diastasis measurements. We categorize them. The diastasis measurements like anterior tibial femoral distance, posterior, and then diastasis and angular measurements, and then you had rotational measurements, translational measurements, ankle motion measurements. So you have all sorts of measurements that have been over the last 2 or 3 or maybe 4 decades have been used radiograph or the static CT to evaluate for syndesmotic injury. So we combine them all and try to apply all of them in a group of pilot subjects, about 20 subjects, asymptomatic ankles, to see what's going on. And as you see, the measurements are not much different. The confidence interval have a lot of overlap. The only one that was a little bit different between the medial clear space, but a little bit different between the weight-bearing and non-weight-bearing CT acquisition. Just to remind you, all this data acquired from this same 27 patients, weight-bearing, simultaneously non-weight-bearing scan. And we did all the measurements in the previous slides. And these are the data. They are very similar. So that tells us that if you try to use this technique, the only medial clear space can demonstrate in asymptomatic some difference. So if there is any difference in any of those measurements between non-weight-bearing and weight-bearing, there might be something wrong. And that's an element or demonstration of biomechanical derangement. That's the first attempt in asymptomatic subject. We are not done yet. So this is also a demonstration of inter-observer variability. All of them are ranging between good and excellent, which is promising for future projects. Then we moved towards the next step, which is looking at the same measurement in symptomatic subjects. This is algorithm of our patient recruitment, patient who came with ankle fractures. I'm going to summarize this slide, which is a very kind of a busy slide. You guys know 10 times better than me what's the indication of surgery. So we did stepwise the exclusion of subjects based on the manifestation, and then in the stress radiograph, any of them were positive, we excluded them, because then with $5 or $10 radiograph and physical examination, you don't need advanced imaging. You route the patient for surgery and you're done. But once the patient goes no to all of these filters, then you get to recruit the patient for questionable, subtle biomechanical derangement. So by this slide, I'm telling you, our data is skewed toward the more subtle, closer to normal syndesmotic injuries. So if we do see some, so I suspect many of our measurements will be different and abnormal if we include all the subjects, not the ones that are excluded. I hope you got me on that point. So This is a very busy slide, a lot of numbers. We try to evaluate the intra and intra-observer. So this is intra-observer, and this is intra-observer variability between the 3 readers for all of these measurements. And that we use a MSK fellowship trained radiologist. We used 2 orthopedic surgeons, one with 5 years, one with 10 years of experience, and we ran all these measurements, all 3 of them. It was a very cumbersome project. But the results were interesting. All over the results are good to perfect in terms of ICC. A few of them, like here on the rotational measurements, show some level of low inter-observer variabilities, which is quite expected. But overall, the results is very promising. So, and then we move towards to see which of these are kind of which of them are more sensitive in this group of subjects who are symptomatic but not directly candidate for surgical repair. And we found of those the posterior tibial fibular distance, diastasis angular measurements demonstrate some elements of difference when we compare the weight-bearing and non-weight-bearing measurements. But the results are not really of a high p-value or high separation. And if somebody says to me, if you do correction for multiple comparison, that significant result may go away, which is absolutely true. But there are good reasons for that. First of all, our symptomatic subjects are very well selected, so we don't have all the really bad joints that are really candidate for surgery. Second, we have only 27 subjects, so our power is not really high enough. So moving forward, this is going to be my last slide. That's where we are staying right here at this point at Johns Hopkins. We try to move from personalized measurements of using every person, we give them the predefined anatomical landmark. We are using a semi-automated. Our friends using active shape models framework. We we develop a software, and basically what we do, we use the CT images, and a radiologist or reader find the anatomical landmark of 7 or 8 of them, and then all the measurements will be populated like a report of, like, say, or CBC. All the lines will come out. That makes that saves a lot of time. That improves the intraoperative variability, and then agreements between the readers will also go high. So, having said that, we are in the process of going from non-automated to semi-automated, and I'm sure there will be future attempts that you can basically pull the entire volume of a CT, and you get all the numbers without any human involvement, which is our future goal. So I stop right here, and I thank you very much for your efforts. We are in the beginning of the road. The road is really exciting. This has been 3 or 4 papers that I just squeezed together for maybe the first 10 or 20% of our mission statement, and I'm happy to answer any questions you have.
I think going to be one of the general questions for me today. How much weight do you put in your weight bearing, and how do you control that?
That's a great question. That's a very important question. So we are not sure we're doing the best possible way, but we are doing it consistently among all the subjects. The way we do it is that the symptomatic joints, the patient will stand on both feet. It's standing position. The feet are at the same level when we scan, and patient gets like a physiologic weight bearing, not one leg carry entire weight or vice versa. Of course, this is an ontologic thing. Like patients is a lot of pain, he cannot control how much weight he puts on the symptomatic leg. That is out of our hand. But the way we did it in terms of our imaging protocol was very, very consistent, at least from the examiner or imager side. I hope I answered your question.
Thank you. It's excellent work. When you went down your chart, why didn't you scan some of the patients that were going on for surgery just to get some data on the...
We do have that. We did those, but I wanted to bring this part because I think... So what happens when we get the scanner, we write the grants to Kirsten, and we get the basically funding for doing the research. Those are the part of the specifications of the grant. But for me, to present this, I basically require all the relevant data that I have to go for my mission statement as a PI on this whole effort. My goal is to detect subtle biomechanical derangement that is falling through the crack using other conventional techniques like MRI and X-ray. I mean, of course, like a surgeon goes in the OR, do it under anesthesia, put a lot of pressure, can see subtle biomechanical derangement, but that's not optimal. You don't want to put the patient to sleep for that question to be answered. I hope I answered your question. But yet, we do have other projects that answer your question.
Right, excellent. So again, if there are any other questions, we can stay over a little bit longer and have discussions. Thank you very much, Dr. Demary, for this excellent presentation. So now let's call Professor Ziegler, and here's the mic.
Thank you. Thank you for having me here for this presentation. So I'm going to show you a way of processing the data that we came recently with, which I think that may have some really interesting input for interpreting the weight-bearing CT data. So in terms of the introduction, functional deformities of the foot and ankle are very often associated with abnormal bony interaction, and often that occurs at multiple joints. So you see these examples. Now, weight-bearing CT is an effective tool to visualize this 3D foot and ankle morphology and the bony interactions under functional loads. However, the new data processing and measuring techniques are required to take full advantage of this of the 3D nature of this modality, obviously. So the goal of this study is to provide a comprehensive insight into the intra-articular joint surface interaction at the foot and ankle using weight-bearing CT imaging. So, in terms of the intra-articular joint surface interaction, we basically have different ways to look at it. One way is to look at the contact pressure at the joint. And studies that were done in the past, you can use what's called a pressure-sensitive film that can go into a joint to measure that. And obviously, that you can only do in vitro. You don't get relative surface position, and obviously, it's not clinical. Another method for contact pressure is to use finite element methods. However, again, the problem is that it's in silico, meaning in the computer, and then it's time-consuming and complex, and it's not subject-specific typically. So again, not clinical. Another method to look at it is by looking at kinematics. We can use external or internal markers to follow these joints. Clearly, with external markers, we cannot look at the interaction at specific joints. And with internal markers, again, that can be done on a very limited number of subjects, and it's not, again, not clinical. The other method that recently came up in the biomechanics community is the imaging that is based on what's called dual fluoroscopy, where we take a very high resolution image, 3D image, like in MRI or a CT, and then we use dual fluoroscopes to follow the subject as, for example, during some functional activity like walking. And from that, we can look at the motion between the bones, at the joint interaction during the actual motion. However, again, problem, high level of radiations, and it's really expensive, complex, and it's, again, not clinical. So then we come to the relative surface position, which is basically what I look is at a combination of weight-bearing CT together with distance mapping. Some of the advantages is low radiation and high resolution. However, it requires, obviously, image processing, and there is no contact pressure information that is provided through this. However, clinically, it's feasible. So what's distance mapping? What is this thing that I talk about distance mapping? So we start, obviously, with the foot. The first thing we had to do is segment the bones. So here is the bone segmented. That's the first task, and obviously, it's a very daunting task. It's a really difficult task of being able to segment the bones, and people are working on this from a variety of directions. Once we have this bone segmented, though, we can look at the interaction. And what you see here is a distance map superimposed on different bones at different joints. And as you can, I hope you see, is that you can, with one glance, you can really capture quite a bit of information that is captured in at all of these joints. This color, by the way, that presents the distances, as you can see there on the scale. So what's the definition of these distance maps? Here is two surfaces And basically, you do a grid on one of the surface, on one of the bones, create like a grid as fine as you want, and you look at the distance. Basically, circles that go from the focal point until you hit the bone on the opposite side. So that gives you the distance. Then you also look at the normals, at the angle between the normals or between the two surfaces to decide whether it's included in the distance map or not. And then you create your distance map. Here is, for example, for the subtalar joint. And what you can also do, you can divide that regions, those surfaces of interaction, you can divide them into regions, specific finite regions. And for each one of these regions, you can calculate averages. You can look at the standard deviation of the distance in the specific region. So you can apply some statistics to look at the directions in which joint change their direction with different pathologies. Now, we did some validation studies using different phantoms simply to verify the accuracy of this distance map technique. And we got pretty good accuracy. Of course, this accuracy depends on the resolution, of course, of the scanner that you're using. So since we're using a resolution about 0.37 millimeters, both sides, it comes to around that number. So the methodology that we use is starting with the DICOM file. We were using this on 30 normals, so far at least, 30 normals, 10 valgus, 10 varus, 20 chronic instability patients, and some 10 hallux valgus patients. We then go through segmentation of the data. This is semi-automatic segmentation. It's not fully automatic segmentation. We're using for this a program called Analyze Direct that was developed at the Mayo Clinic. From the segmentation, we then generate the distance maps for the various joints. And as I mentioned before, we partition the articular surfaces into specific regions so we can look at the changes with different deformities that are taken in these different regions of the joint. And finally, we can submit this to statistics. So this is the process. So here are some of the results. So we look here at normal. This is just, of course, one typical subject with normals. Here is a valgus, and here is a varus. And this, of course, when you look at it, it's hard to get all of the details. So I'm going to show you some of the more detailed information. So we can see here normal, valgus, and varus. You can see that as you go, this is at the ankle joint, as you go into that valgus deformity, there is approach on the lateral side. So the lateral side is approximated, while in the varus, it's the medial side, it's approximated. And the numbers, the statistical numbers based on the patients that I showed you, verify that, provide you a verification of that. At the subtalar joint, very interestingly, here is the normal. In the valgus patients, as you can see, there is a tendency, the talus is moving into the sinus tarsi over in the front, and you can see that there is a direction of basically of the coverage to move into the sinus tarsi and into the facet, in the middle facet. And here, the opposite occurs in varus. The talus is basically backwards and over the sustentaculum tali. The numbers again verify this. What happened at the Chopard joint? You can see that in the valgus patients, there is an approximation, slight approximation on the superior medial side. And the talus on the varus patients, it's a little different. In other words, there is some separation, but not significant. The other joints, the cuneo-navicular joints, not much of a difference between any of them, between normal valgus or valgus. And the same thing for the tarsometatarsal joints. We didn't see any significant difference. So this is for the varus and valgus patients, and that's basically what I wanted to show for here. But let's take a look at chronic instability now. So for chronic instability, and this is, by the way, one of the things that I think it's important to realize, that often when you superimpose on the weight bearing some stress. So for example, for chronic instability, we can impose a stress from neutral to an inversion. So what you can see here, for instance, right? This is the neutral. This is the same patient. It's the same subject, the normal subject, going from neutral into inversion. You can clearly see that there is an approximation as you go into inversion on the medial side. And look at the subtalar joint, how it approximates into the sustentaculum tali. Here is a patient that has a bilateral chronic instability. It's hard to distinguish from here which is the more unstable. But when you look at the results, notice that the left side is significantly more unstable than the right side. Not much difference at the subtalar joint. In other words, the instability of the subtalar joint doesn't seem to be present much. So what's the future for these distance maps? Well, I think the future is really unlimited, because all this methodology gives you is ability to visualize and to quantify the interaction that occurs at the joint. So, for instance, this is a case what we are doing right now. We're looking at the effect of, we're going to look at the effect of different osteotomies on the hallux valgus. Here's an example of a normal, and here is a hallux valgus situation. Here is the distance maps for those two situations. Clearly, you can see the difference that is between the two. Obviously, the effect of the surgery hopefully will be to bring it into this situation. Then, as I mentioned, another important thing is this stress. I call it stress weight-bearing CT. In the past, we were using stress MRI. But with the weight-bearing CT, it's much more effective, because on top of the stress, you're also imposing the weight-bearing. So you basically have a composition here of weight-bearing combined with an inversion stress. For example, for an syndesmotic injury, you would to accentuate the effect of the injury, you may combine a axial load with external rotation, which would then accentuate the difference. Then to look at the syndesmosis, you can simply create a distance map between the fibula and tibia. So in conclusion, the distance map provides insight into the interarticular surface interaction. I hope I was able to demonstrate it also in the quantitative way, not just qualitative way. It covers great amount of data in a comprehensive and meaningful way. In other words, with one vision into the joint, you can identify where the problem may be. For example, there was a case here of a valgus deformity where you could see approximation at the second and third metatarsals, suggesting that that may be a point where you need to look more carefully for that particular patient. It helps identify and quantify abnormal surface interaction. And in conclusion, in conjunction with weight-bearing CT, it may become a useful clinical tool for diagnosis and treatment evaluation of a variety of foot and ankle deformities and instabilities. Thank you.
So a couple of questions maybe for Professor Ziegler?
Yes.
Hello. So my question would be to do a little bit with the segmentation process. So I was wondering, how do you split the cartilage exactly, and does that affect the distance mapping measurements?
Yes, so very good question. We don't. We just look at the distance bone to bone, because this is coming from the weight-bearing CT and not from an MRI. Mm-hmm. So the cartilage is not visualized. So it's really not cartilage to cartilage interaction. It's really the bone to bone distance. So you have to. Yeah.
So when you segment, do you basically cut somewhere halfway between the two bones in case?
Oh no, the segmentation simply follows the bone.
Okay.
The segmentation follows the bone surface, mm-hmm. Not the obviously.
Because in the first image that you showed there, the bones seem to be really close to one another. So I kind of.
I'm sorry?
In the first image that you showed there, the bones seemed quite close to one another.
Yeah, but there is a millimeter or so of separation.
Thank you very much.
Maybe a quick one.
Sure.
I guess you would do something similar after a replacement, knowing something about the prosthesis which is implanted. Can you do
yes,
that?
you could. Yes, you could do the same thing for a implant or for looking at distance maps at an implant or anything. Yes. Yeah.
I was going to do it as part of the talk, but as I'm doing the talk next, I'll ask you now. But it's amazing how information is like rain, okay, and ideas are like rain. So we, in parallel, without knowing each other, have developed very similar methodologies. It's amazing to see that you got there. But one of the things in that standing slant that you had, where people were sitting, so we developed almost identical looking wedges, just again completely independently. And so one of the things we found is that when you put your foot onto the wedge, you've slipped off, and so we ended up just doing it on the flatter surface. Do you think they may have? This is not interested as much in the weight bearing load because it's looking at the positioning and the distance between the bones, but when you stand on those two unstable things, you can't put your full load on. A lot of it will be balancing.
Well, you do put full load. You have no choice but to put a full load.
But you're having to balance. So
minimal balance, and the wedges are not so extreme that you cannot maintain your balance. Actually, even patients with chronic instability can maintain their balance on those.
And do you think the next step will be a way of determining loads, as in forces across the joints?
Yes, and you can do it by putting a pressure mat under the weight-bearing CT, obviously.
No, but how would that translate to forces between the joints?
Yes, you need a model for that. You need a structural model for that. That's not a simple matter. Yeah. You need a structural model that would combine the pressure distribution information with the changes in position that you get from the weight-bearing CT. But that's
going to be exciting. Yeah.
It's a complicated, but yet an exciting. Yes, absolutely.
Thank you, Professor Ziegler. So now we're going to hand the microphone to Professor Richter, and he's going to tell us about his long experience in thousands and thousands of CTs. Thank you.
So, ladies, yes, we have ladies. Ladies and gentlemen, is this working? For the recording. Hey, hello, recording. How are you? So I'm a little bit late and exhausted because we had some in the General Assembly. We had some serious discussions. So now I'm happy that I'm here, but I must go to another room. So therefore I had to step in now, really rude, to go to the next room. But of course this is the most important here, as I said in the room before and in the next room. But this really is, because this is the most exciting and the most fun. And this is also the most sexy what we have here. This is a cool device. And I have it for a couple of years now, and I'm really excited about it because you know, I don't want to tell you too much about the basics. When you have a 2D investigation with X-ray, you have a problem with a projection, and you have the problem with a position. As you can see here, this is different projection, the same foot, different angles measured, but it's the same angle in the foot, but only differently measured, or with a different position of the foot. You can see here there's even a fusion nail in the hind foot, so the position is absolutely the same. But only by the different rotation you can see the different values here. So this is dependent of the position of the foot, which is another problem with the projection. In the 3D, you have no problems with projection and no problem with position because you gather the entire volume, but you have a problem with the weight bearing in the standard CT. And you can see here in this Charcot foot, you see with weight bearing, it's a severe flat foot, and it's the reason for the cause of the ulcer here, which can cause even amputation. But without weight bearing, it doesn't look so bad. So the weight bearing is also important, and this is what we get here. And who of you has a device already? Okay, so the majority does not have, so I like to show what you get. This is otherwise I could skip it really fast. You can scan both feet at a time with one of the devices. I've only experience with one of those. So the session here is about weight-bearing CT. There are different devices. I have only personal experience with this one. You can also generate X-rays with all the devices. The scanning area is a little bit different. And what do you see? Do you really see better? You can assess yourself. Do you assess the sesamoid position in this X-ray with a metatarsal skyline view? Or can you see it better here? You can assess yourself. What about a suballis frank injury? Do you think you will see this on a plain X-ray or on a CT without weight bearing? Or here, total joint replacement, especially if you have a fixed bearing, the rotation between the tibial and talar component must match as good as possible. In the mobile bearing, as this one, it can rotate a little bit, but in a fixed bearing it will not rotate. And what about the rotation of the tibial and the talar component under weight bearing? Does it really match? Do you know? I don't know. If I implant it, it never matches. So that's the reason why I use one of these mobile bearing. But now the newest style is we don't need mobile bearing anymore because we can implant perfectly. I cannot implant perfectly 1 degree maximum deviation between the rotation of this and this. And maybe sometimes it's good to have a visualization, so I do it also in all patients. So this is what you see. This is qualitative. And the typical American way of life, is anybody here from the United States? Elaine over there and there? It's fantastic. I see everything. But for me, I'm suspicious European. It's not enough for me. I want to have science behind it. So we started with science, and there we started also, but it was not my idea. It was the idea of the younger and much smarter researchers to have this weight-bearing CT international study group. But we did science before, and I was looking into a very first study in 2014. It was already published. We compared the special angles here, typical angles, as for example the intermetatarsal angle or other angles between X-ray and with weight-bearing CT, without weight-bearing, and weight-bearing CT. And there was no surprise, this was published, and also that there is a big difference. And then it was also shown that there is also difference between weight-bearing CT and standing weight-bearing two-dimensional imaging with X-rays. And the conclusion about this was, first, it differs, but if it differs between 3 methods, it does not say that one is right and the other one is not right. All 3 could be wrong. But if only one can be right, because they have significant differences, one can be right, and the other 2 must be wrong, or all 3 must be wrong. So I don't know which one is wrong and right, but from a technical standpoint, only the 3D imaging with weight bearing could be the right one, could be. I don't say it's the right one because we don't know the angles. I must remind you, we don't know the real angles of the foot. If we want to know the real angles from Mr. Goldberg here, we measure the angles, and then we cut off his foot, and then we measure the real angles inside his foot. But it's not really feasible. So we must think maybe this is the most accurate method of the methods we have, and maybe that's the best thing we do have. So when you go to PubMed now, and it's very easy, you can click on the Weight-Bearing CT International Study Group website, a button, and then you come to this PubMed site with 2 to 59 other studies, and they're all about accuracy. So it's scientific approach. And some of you are really scientific, even doing more science than being in the OR or doing only science, like some of you. You probably don't do operations on feet, no. So these guys are the smartest ones, they do only science. And some of us, they go only to the OR, and some of them are in between. So when you are not a researcher who is interested in the research potential of this, research potential, you can add another 50 studies here. But if you're not interested in this, but just you want to treat patients, you're probably more interested in what happens to the patients. And first of all, do we need it at all? Do I need it? So the problem is, and it's not the problem, that with standard care, we are all skilled foot and ankle surgeons. We have greater 90% good results anyhow. So does it really improve? I don't think so, because we are good anyhow. So to come from 90% to 91, does this device help you? I'm not sure. But it helps you when you want the highest accuracy and the best visualization of bony structures. This will not it will not make the patient worse. Maybe it will be better, but this is not proven yet. So now what about the benefit in the hospital? There's also other benefit like cost and like workflow. And now we have done more than 2,000 to date, more than 10,000 weight-bearing CT scans since 2013. And we looked in a study, 2 groups before and after. So group 1 was the radiographs and the CT in 2012. And group 2 was from 2013 up to shortly before here, 5.2 years, and then we made a yearly average, and that we compared. And the time spent was calculated by an earlier study. Radiation dose was calculated by an earlier study, based on an earlier study, and then the cost. And the device cost you can see here in our environment. And for the other devices, we did not calculate any cost because we had X-ray and CT, so we didn't have to buy that. I click it away. Ha! Now you can have it later. So here's now the study with the patients. The scans were not in 10,000 patients, but in 4,700 patients. You see 47 all achieved preoperatively and some postoperatively and some even more than one postoperatively, as you can see here. You can see the range of deformities. It could be also different deformities or combination of deformities. So that's what we do. That's what we do in our hospital here, with these 10,000 scans in for almost 5,000 patients. So now what we have here, this is the two groups now, the R and CT group and the weight-bearing CT group. This is the radiographs. We still do some radiographs because postoperatively we don't do a CT scan or a weight-bearing CT. But here we have much more CTs. There's the CTs per year, 254. And then you can see the results here. I must do it on here. So one big issue is the radiation dose, which is lower with a weight-bearing CT, but not because it has a lower radiation dose than X-ray alone, but because it has a lower radiation dose than X-ray and the CTs you achieve in some of your patients. Second is the time consumption, and this is for the radiology technician, and you think they don't cost anything. In Germany, they have an hourly earning of 40 euro, so it's a cost factor. And this was decreased from 959 hours to 127 hours, so it's a risk of reduction of time, as you can see here. And the time spent also per patient. You can see here 16 minutes here for the X-ray acquisition and the CT together, if necessary, and here only 3.5 minutes. And it really increases the workflow and the profit here, even if you're not a radiologist. This was just break even, and now we have a little bit of profit, but we don't charge all the patients, we charge only the private patients. But this is a good argument when you're talking to your CEO of the hospital. It's not making a lot of money, but it's not also losing money, at least if you use it frequently as we do. So do we need this technology? Yes, because you have the best visualization, that's without any doubt. Better than with a CT alone, or better than with the standard radiographs alone, or better with a combination of those. Yes, if you want to decrease the time spent in your radiology department significantly, hundreds of hours, times 40 euro, for example. It's really a cost factor. And yes, for a decreased radiation dose, this is not as significant, but only because of the high numbers. So it's not I think it's not the main argument. And yes, for increased financial profit, even if you're a non-radiologist, here. But we have a radiologist here, do we? I wonder why the radiologists do not buy all these machines, but it's good. So maybe we can step in a little bit here. But it's not mainly for the money. But this is important because you don't lose money. When you go to your CEO, you say, I want this. By the way, it's 200,000 or 240,000. Then they would say, 240,000 euro. Then you can say, but after 5 years, it's break even. And if I use it longer and it's working longer, then we can make a little bit money. This might a little bit help. But of course, this is not the main argument. The main argument is that we want to help the patients. And there's no harm, and we do not have a higher radiation dose, which, as suspected, it's not true when you look at the entire population. Thank you for your kind attendance.
Thank you very much for this exciting speech. Does anyone have any questions for Professor Richter?
The radiologist.
Amazing talk. And one quick question I have, which is out of my curiosity, there is a huge, I think you have the largest sum of patients around the globe. That's my guess, my educated guess. If you want to sort 3 main indications among those subjects that you did over the last several years, can you please list them? Yes. Because I would love to know what are the main pathologies that have been looking at.
That's a very good question, but I didn't ask you to ask this question because for me the 3 indications is the next 3 patients that come to my office. I do it in all patients. We started first, we said, okay, forefoot we don't need, it's so easy, we start with the hindfoot. And children, no, the radiation, we don't do it. So let's do the hindfoot and the midfoot. Then we said, oh, it works quite well. Let's look in the forefoot about the sesamoid position. Then we did it in the forefoot, but not in the children yet. And then we had a number of children with flat feet. And then we said, okay, then we go below 18 years, which is adult in Germany. We go to 16 and to 14 and to 12 years. And now we do it even in children, because we have, with the new software, the radiation contamination is even less, the radiation dose. So for me, it's absolutely clear. For me, in my environment, it's the next 3 patients, no matter what they have. And it's so clear to me that I even don't look at the patient before. They go to they have a scan before they even go to my office or the office of the consultants. We do it before, and even if they have X-rays, weight-bearing X-rays, we don't have the information. Some patients, they say, no, I want to see the doctor first. I don't do this thing here. And then we look at it, and in 100% of these cases, we say, okay, not bad, but you need more information, so please do the scan. And this is not for the money, because the money does not go to my pocket or to the pocket of the consultants. It goes to the hospital, so it's not for the money, it's just for the information. And our workflow is, the patient comes in, he fills out all the scores that we have, they have a pedography, they have a PET-CAT scan, and then they see the doctor.
I just want to clarify that. So someone comes to see you with Achilles tendonitis or Morton's neuroma. Surely you don't scan them before you see them?
Sure, I do.
You do?
I do, absolutely, because a Morton's neuroma could also be a metatarsalgia. Achilles tendon could also be a heel spur. And you must, if you have Achilles tendon pain, you must look, is there a Hecklon deformity? Is there a spur, posterior or plantar? That's at least my opinion. And of course, then they get in addition also an ultrasound, for example, or an MRI. But this is really, I'm absolutely honest, and Arne can agree on that, because he was in my hospital just last week. Also in that, even for a Morton neuroma, if this is the diagnosis from outside.
I think we could add something here. Would you operate on Morton's neuroma or Achilles tendinopathy without having your plain X-ray set?
So I think the likelihood would be the majority of them will have an ultrasound, say, and an injection, and very few of them go on to surgery. So in that situation, I would only scan those maybe that are going on to surgery. But
Not scan, I mean plain conventional radiographs.
Again, it depends on the clinical indication, but I always do the clinical assessment first. I understand the process of doing the scans first, but I don't think I could justify, if I don't think it's a bony issue, doing a scan before I see the patient. But clearly, if you think there's a clinical indication, then you could do it. But I think we'd struggle in the UK of being able to do the scan before seeing the patient in case you're doing an inappropriate scan.
Yeah. But, let's go to the easiest thing. You have a Morton neuroma. You are sure, and then you resect it, and then you would send it to histology. And yes, it was a Morton's neuroma. The patient had pain before, and afterwards completely healed. This is a typical case, but it could be also a metatarsalgia. It could be something with a bone. It could be something like that. And the other way around, when you say, so Martinus is doing so many scans, he goes to hell because he has done non-indicated radiation doses to patients. The other way could be the same, because you have done a surgery, but it was not a Morton's neuroma, it was something else, maybe a little spur in the metatarsal next to it.
I would say
and then you
of patients don't have surgery.
Yeah.
So on those having surgery, I completely concur, but
yeah.
For the majority of patients that
don't have surgery,
then I can't buy that argument,
yeah.
Because if you're not going to have surgery, then you can't argue that you made the wrong diagnosis, because the fact is they've been treated by other means, yeah, without any radiation.
Yeah. I think it's a good discussion, but we don't have to have the same opinion, all of us, because it's different environments. I'm sorry, who's this? Mr. Trump? Because we have the different, sorry for this, I take this, my wife, it was my wife. It's different environments, and it depends in which situation you are. So I work in a big hospital, and 100% of the patients were seen somewhere else and got some treatment. 100%. It's very, very, very rare that a patient comes directly to us. because of the system. And when you are in a private practice, maybe you can also, you can of course look at the patient before and you can do a scan later on. It's just important to show that there are different ways. It's not one way, apodictic, you have to do this, what I say or somebody else. I just tell you what some of us do, and then you can decide yourself what you can do afterwards.
I think
there are different ways to the goal.
If you need a conventional X-ray, like if you need it, not necessarily this patient that you're not going to operate on, but if you need it, just forget about X-rays and get a cone beam CT, because you get more information, saves money for your hospital, saves radiation, maybe not for this particular patient, but on the global population if you have this mindset. So this is more this kind of discussion. Thank you, Professor Richter. I think we have to move on to Dr. Goldberg.
And I must leave, I'm sorry, but you were still the best room.
Right.
From your computer.
Yeah. You got the button, yeah. Let's just see if this works. I'll stand here and do it, don't worry. Okay. Thank you very much for inviting me to come and talk here. My name's Andy Goldberg. I'm the end of this list of collaborators. This is a project. I work in London in the UK, which until March next year is part of Europe. I work at lots of hats at UCL, clinical hat, doing research now in the NHS and private practice otherwise. What this project was when I came out of the station, there's a nice picture by Einstein which said something along the lines of the quote is, we need to know our limits before we can exceed them, yeah? And a lot of the time in medicine, and in orthopedics in particular, we go developing stuff without actually knowing our limits. In other words, we have no idea how a joint works, and so we go and develop a joint replacement because we're on a whim. And in particular for the problem that we're going to talk about, that was done in 1970. Fornell did 100 patients with a subtalar joint replacement, and the failure rate, unfortunately, was 100%. And it was largely because we didn't really understand how the subtalar joint works. So it's a complicated joint, and I don't want to bore you. This is an hour's talk. I've just tried to condense into 10 minutes, so I'm going to cut to the chase and not go through too many of the details. But in essence, this is the problem, okay? The subtalar joint, so this is not the tibiotalar joint, and this is the joint below the tibiotalar joint, inverts and everts. It just rotates. That's all it does. That's eversion, and then the other way, the other direction, is it inverts. There's lots of ligaments and things between them, but that's effectively the only motion that the subtalar joint does. And because of the shape of the calcaneum, you get heel inversion and eversion, but you have no inversion and eversion really at the joint, and certainly not while loading or weight bearing. And that joint, if you look at it, has sort of been described as 3 separate independent facets. Although they're independent, they don't have independent motion. Okay, so you think of it as like a door hinge. The door hinges are completely independent of each other, but that door can only work if the 2 door hinges are working together. And obviously there's lots of ligamentous structures around it that are holding it, very strong subtalar ligaments. Most of the time when someone sprains their ankle, they also sprain the subtalar joint ligaments, but if anyone can find me an MRI report where someone has commented on the subtalar ligaments, I'll pay them $1. Very rarely do they do that. They're routinely doing it now for us because we've got an interest in it, but most of the time they'll comment on the ATFL, the CFL, in other words, these ligaments, but they won't comment on the subtalar ligaments, which invariably will be damaged. And what I won't do is bore you a little bit with all of the published papers that have talked about subtalar motion, because they go into sort of complexities trying to explain things like a mitre hinge. It's just a little bit nonsense, to be honest. It's very difficult to try and fathom the picture that I showed you before using these models. Masira did a beautiful paper, as always, and showed it in these columns, saying there was a blue column and a red column, a medial column. The medial column here is blue. And when they lie next to each other, the talus is everted, okay, in relation to the calcaneum, and the foot's unlocked, and it's acting really as a shock absorber. So you're positioning your foot on the ground. But then when they overlap, it locks, okay? And there's a eversion, and the as you can see here, the talar head is sitting on top of the calcaneocuboid joint. And again, lots of science that's been done to date, sort of based on anthropometric studies where they're looking at the talar axis. Very scientifically, they passed this through the central axis of the talus. How they knew where the central axis of the talus is where the science sort of falls a little bit. This one somehow got through ethics. It's an in vivo study, okay, where they managed to get 3 male volunteers, slight conflict of interest because they were PhD students doing it on themselves, which you can sort of allow, which is they stuck that right through the ATFL actually. So, but you were walking a little bit like this, and they were trying to sort of assess motion there, coming up with some of the information which we now have. This was a very nice paper looking at the instantaneous helical axis of both the ankle, talar crural, and the subtalar joint. It's a very nice paper, beautifully done, beautifully illustrated in terms of how they did it and how they showed the measurements, very scientific in terms of the way it did. But realistically, they concluded that there was an instantaneous helical axis of the ankle joint, the tibio-talar joint, but not of the subtalar joint. They couldn't determine that. So we're left really with this sort of thing, this sort of concept, that the joint is orientated at 45 degrees in the sagittal plane, 23 degrees in the medial long axis, and that there's flexion, supination, adduction, or extension, pronation, and abduction. It blows your mind trying to work out what's going on there. So that's kind of where we're at. So trying to solve that is almost impossible unless you can understand, from my mind, well, if it's rotating, then where is that centre of rotation? So that's what we said we were going to do. So our study is effectively we had to get ethics approval to allow people to be scanned. Okay, we've got 8 healthy adult participants. All of them were scanned in a bipedal scan that we've talked about now. It takes a minute. All of them in 3 positions: high arch, flat foot, and a neutral position, using similar technology that we've talked about before, which is our wedges. So we did originally have them off the ground, and what we found was that people were sliding off. We tried different surfaces to stop people from sliding off, but we determined that realistically the foot would need to go here and here in order to allow the person to, so that you can see it. It's not very coming out very well, but you can see the person being scanned. That's closer up version of it, but one very inverted and one everted, and just as we saw before, beautifully show much nicer images. That's the position on the scanner. Then what we did is we manually segmented them. Okay, we used a software called Aviso, but there's plenty of softwares out there. And defining the colour contour, if you like, of each of the bones, we were able to then sort of work to registration. So the positions were marked on really by surface meshing, and we created where the joint surfaces were, and a cloud of points we used to sort of manipulate that. Once we got those, then we had to think, well, how do you get the 2 bones relative to each other? And a very nice paper by Parr et al. Looked at 2 helical centres of axis. So if you've got 2 spheres, then it's actually the line that's going bisecting both of those spheres is the centre of rotation when you've got a complex joint like the subtalar joint. So we used an existing methodology and a dedicated MATLAB script that we built. We had a PhD student doing this. And the central point of the spheres represented a good approximation for the center of rotation around the facets. And we estimated 3D vectors. This is the data, the first 4. The last 4 was only done this week, so I haven't got the data in this presentation. But in essence, this is to show you where we were getting with the center of rotation. We hypothesized a single center of rotation. Okay? And that roughly falls here on the middle facet, which is what was predicted preoperatively, if you like. So we had a hypothesis that there was a single center of rotation, and we've proven that hypothesis with this work. And that around that single center of rotation, the joint moves. So this is what it looks like in real terms. That's all you get. Okay, center of rotation here, and the rotation is eversion and inversion. I'd like to thank my study collaborators. This is Professor Gordon Blunn, who's developed many hip replacements, Jamie Swania, and this is our room in Stanmore. It's just great to be involved in stuff that I author love. Thank you.
I think we have to speed up a little bit, but we have time for a question.
Nice job, Andy. We've been doing something similar some time ago in your country, you know. We have
It's called Oxfordshire.
Yeah. We have observed something different in your way to inversion rather than to eversion. I wonder if you have put all the 3 steps together, or you have analyzed, distinguished the 2 directions of motion.
What do you mean?
You know, from your neutral, you go to inversion
So
on one
that's
side.
eversion, and that's
Yeah.
inversion.
Yeah, yes. Our observation was the axis of rotation was different in the 2 directions. For a single center of rotation, you should have taken, you know, the 3 position all together, or you can actually find the axis of rotation in one direction and in the other direction. So basically, if you have split the motion, what we call motion, in between these two, all together.
No, we found the same. So this is the same image. Blue is neutral, green is inverted, red is everted. So effectively, that consistently mapped on all of the 8 subjects. And there were 3 scans, weight-bearing scans per patient. And I think this is the first weight-bearing data that you looked at. So I think, we wouldn't see the same if you did a non-weight-bearing image. I think that's very difficult, because when you're testing this in a non-weight-bearing situation, you're going through what we said before, which is where that's why ankle sprains happen when you're weight-bearing. They don't happen. So you put your foot down. That's where you dedicate your subtalar joint position, and it's only when you lock it that you go over, because you're relying then on your ankle ligaments, and it's a very different philosophy when it's weight-bearing, I think.
Okay, great. Thanks for the mic. So we're going to call Dr. Mikkelsen for the next talk. Thank you, Andy.
Wonderful. Hello, I'm Oliver Mikkelsen from Finland. I belong to those surgeons that do spend most of my time in operation rooms. Sometimes I'm dragged out of the operation rooms, and in the worst days I'm given a microphone. No, it's wonderful to be here. It's great. We've had actually this one weight-bearing CT is a wonderful place. It's so many opportunities, so wonderful possibilities for all of us. They are endless, the possibilities to use it, I think, in a foot and ankle surgery. Actually, we've been doing it for quite a while. I got my first machine to the University Hospital. I don't remember if it was 2006 or 2007. when we started it with a Finnish company who provided us the first material, and we started to analyze things. And then if you take, this is one of my colleagues' feet, that's a normal foot without no instability, and we put the foot in an eversion, but then we put in a plantar flexion and inversions, and we can see the instability, the movement of the talar joint in just a normal, not unstable foot. And then we can think about, as an old traumatologist, that think about the methods when trauma happens, when the navicular is very close to the talus. We think about the cartilage problems, how those bones can really join each other and be very close. MRIs have been always the golden standard. I want to show you some pictures of cartilage screenings, because I think that's something we do in Finland and you might not know. It's not, we use it the same machine, and then I will show you some implants and effects we are using it in a clinical work, and also been a bit practicing with new machines. Both the sensitivity and the specificity in MRI is quite low, actually. We believe it's the truth, but we know in the clinicians, we often do an arthroscopy, we see the cartilage problems inside of the knee or wherever, and we can't rely 100% of it, so we need even better instruments for that. But we are very lucky that guys like Andy and many other guys are doing research also in this field, so the number of publications is increasing, but unfortunate, it's quite low in foot and ankle field. You went through it, this actually more clearly, it's more pixels in this 3D CT. When they don't make it in 2 labs, it's more like a 3-dimensional pictures. So if you look at the cars, this is the difference between having good pixels and having a lower quality of the pictures. We know it's a low dose method, and here we see the first picture. When you look at in the middle an MRI picture, on the right side you see an arthrography made with the CT, and you see a clear dark area on the cartilage. You can all see it here. There is nothing in the whole MRI. And we look at the ankle, and this is the same patient inside the ankle where you see a clear cartilage problem. We can also look at different kinds of other angles. This is a bit different kind of cartilage problem, and you won't see anything in your MRI, but with a CT arthrography, it's very visible, if you can see them. Okay, and there you see the cartilage problems, and you see it in an MRI, you only see edema. OCDs, of course, it's very clear for everybody who's doing clinical work. It's so much more reliable in a CT because we see the bony lesions and so on. But also, if we are having cysts, imaging cysts, in an MRI, you only see it's filled with the filled with the white matter or whatever. But in a CT, you definitely see that there is also a hole in a cartilage. There is a line going directly from the cyst into the joint, and that's a very valuable information of us when we are doing a pre-operative planning. Okay, we can also look at big bony lesions. Here's just for an example, one young sportsman, he has the Finnish record in 16 years old in distance jumping, but his ankle is full of small bony pieces. He could still jump, it's amazing. But in the MRI, you really can't see those bony, special extra bone pieces in this one. But in a CT, it's extremely clear for me, for a simple orthopedic surgeon, to see where the bones are and how clear you can be seen. And this is a ballet dancer. So as a weight-bearing group, you can think about it. This is a CT where you can look at cartilage problems in full weight bearing. Also here you can see very clear and easily the joint has a small cartilage defects in her MTP joint. Even scar impingement can be seen in a method like this. It has been only published so far in a knee, the results of the group. It's not my results, it's mostly Jari Salo, who is a professor, and also Marko Mykkänen has given, who is in the room, has given some patience to this one, but we are doing cooperation. And this is just one of my patients who first had an MRI because he is a top Olympic sportsman. They did directly an MRI. They just saw some kind of ligament problem with him. He later on had an X-ray, and nothing was problem. He comes to me. He clearly has a medial instability. If you went to Beat's, you heard Beat's presentation this morning. There's a small avulsion, so the whole delta ligament is avulsed there from the medial side. He still went to the Olympics with a huge bandage and so on. And he sent that video into the social media, thanking that his wonderful, happy first time in 1.5 years he can train pain-free. So there are some diagnoses we don't even see in a primary MRI. This is a lady who I know well. She had a flat foot surgery. We're also having these programs that's based on old Nokia technology, using the same materials that can automatically devise and define the material, the different angles of the foot. We can put measure Meares angle. We can put hallux valgus. We can do your FAO automatically without having it. You just put the data, the DICOM in the machine, and it will give you exact numbers of the patient, whatever we can see. This is the patients of the numbers of pre and post-operative measurements of this 48-year-old lady. We even measured the FAO. That was about 13%, a little bit less than 10% after the operation. Here we see 3D prints from the same lady. And we made small measurements. This is pre-operative picture of her calcaneus. This is a post-operative picture of her calcaneus. Here you can see the real models. They look really synthetic, but they're actually the real patient's bones that we've made in a 3D print, and showing just examples how to do it. And of course you can measure them with different colors and so on. This is also a funny thing we can just practice and think about it, but it's wonderful to think about how the foot works for a clinician when I'm planning my operation. How do I change the structure of the bones? On the left side, you see a mathematical model what happens in a flat foot surgery when we do osteotomies of the calcaneus, double osteotomies. You see wonderfully the rotation of the navicular joint, how it moves. It's just not the translation. There's also a rotation of the naviculary when you put it on the place. On the left side, you see a real patient. That's a picture when we are comparing the pre-operative 3D CT to post-operative CT, and then we interpolized it. We make it like to a video. How we think about the computer program makes it like to a video from the pre-op position to the post-op position, and we can think about it, how we move the bones, how they change in the operation. But we have a lot of opportunities. And I only have a few seconds left. I will not have to think about it, but I think with these kinds of imaging, we have to think in a totally new way. We have to find, like you have already started your work, and it's been wonderful to follow it up, to look at the new ways of measurement. We looked at the hallux valgus presentation, and there was a question about that. When we look at the sesamoid bones, they were switched laterally. And there was a bit confusion there. But for me, I think it's a very irrelevant, very important question when I'm planning my operation. Are the bones moved because of the rotation of the first rail, or is there a translation? Because I want to reproduce the normal anatomy, and I want to think about it, even in a simple hallux valgus case. But there are different hallux valguses. There are those ones who have the first rail rotation. We know that there is instability and so on. This is just a simple example, but we have so much to think about it. But it's a big mess at the moment. What I think, I even don't know at the moment what is a normal foot, if we are imagining a 3D CT. And when we have really defined what is a normal foot, we have to think about, together with the companies like you all, many people have done, What we want to know about the foot, what I would like to know when I do my clinical decisions, when I'm sitting in the room with my patient and think about the 3D model when I'm going to change the flat foot organizations. How do I change? Do a lateral column lengthening? Do I medial column? What do I do with a spring ligament? What do I do with a first ray? I have to make those decisions there. And to be able to think how it all works three-dimensionally is very important, not only to look at the mirror's angle and the anterior view and maybe to see the thinkers about. And even in hallux valgus, the same thing. So we have to learn to think about in a new way. And maybe not use the old angles, or maybe we can have some of use of it. And why I wanted to show, think about it, if you don't have an MRI, this is a wonderful way to look at your cartilage, because everybody might not have one. It's a very fast way, easy way, and just if you are looking at cartilage problems, I do think it's much more reliable to see exact and small lesions. Thank you. Sorry, I went a few seconds over.
So I will introduce now Dr. Chris Boots. And are you staying, Oliver? Because Chris has to run after to another meeting. So if you're staying, maybe we can have your questions after Chris's presentation.
Mobile phones, not the other one. So wonderful 3D model. They just implement the technology. How was that? Afterwards. I would be happy to show you that. Yeah, yeah. Because they can do the AFAS, they can do everything. You just put it in the machine. Look at this.
We seem to be having a little bit technical problem.
Only we need the adapter from the screen.
Even though features yeah, also a show. I did not need.
Could you not fix the whole thing with the lapidus, plant flexion lapidus?
I might have to again. The man who operated doesn't like lapidus.
These are awesome.
Two-jig jump, that's a bit. It's yours.
Just for you. But I can show you that.
Okay. It's not that one right here. There we go.
Yeah. Okay. Sorry for the delay. I will speed up a little bit. I was in a meeting and have to go to another one. I work in Antwerp. We have for a long time a weight-bearing CT scan. We are 3 fellowship-trained foot and ankle surgeons, and we do a lot of deformity corrections. Everybody knows of ankle osteoarthritis. I will go quickly over it. It's a very debilitating disease with a lot of pain and functionalities for the patients. And if we go to the arthritis, patients, we always think as a surgeon that pain is the worst, but it's only the reduction of daily activities. So standard is still arthrodesis, but arthrodesis of arthroplasty is not the end stage of our operations. If you see a failure of an ankle arthroplasty or a pseudoarthrosis of the ankle arthrodesis, you know it's not the end. And some young patients present with this kind of disease, so you need something else to deal with those things. So we're doing a lot of joint preserving surgeries. That's not the topic of this talk. The only thing what we try to do is we build up a database filling in on 3-dimensional the data of our weight-bearing CT scan, and we try to plan and make guides on our weight-bearing CT scan to do our corrections of our deformities. I show you, well, everybody knows of the center of rotation and of the deformity, and how do you plan it? We do our regular measurements to find where the congruence is and where the deformity is. And then we start to build up a database. And actually, Arne did it a lot. When we did got our first weight-bearing CT scan, we had a small group of Belgian surgeons, radiologists, and people from the I can see the name probably materialize, who sit together to build in like 100 feet an ankle weight-bearing CT scan and make reference points where if we want to do an osteotomy, that we find where to do it, and where to find those center of rotations where we can try to build our osteotomy in. So I will show you the cases that we did with the dome osteotomy. Why a dome osteotomy? Some coras are at the ankle joint, or sometimes you have a congruency in your deformity, and then it's difficult to go for an open or closed vessel osteotomy, and then probably you need the dome osteotomy, but it's very technical difficult, and it's not so reproducible. So that's why we're using the weight-bearing CT scan to build in our deformity and to measure and to plan and have a reproducible outcome. Cases that show they are 4 years out of surgery. They are done on the protocol that we developed. So you see the standing CT scan. The first is a 48 young male. He's young because I'm still at the same age. Has a right ankle, progressive scale of virus deformity, a weakness in his peroneum to a L5-6A radiculopathy. We built a weight-bearing CT scan bilaterally. We measured it, and we measured it to the contralateral side. We built in our reference points, and then we made our tools. We drawn our osteotomy. We can have a predicted outcome of our osteotomy, and we made 2 guides. One is the guide that you use to do your osteotomy, and the second guide is a reduction guide, that when you do your fixation, that you can have a reduced position when you do your fixation. This is the post-op picture of this man. He's well balanced, pain-free, but still the problem is you know what your ankle is doing, but you don't know what your foot is doing, so you still have to add some additional procedures, like if you have a very steep first ray, you have to do a dorsiflexion osteotomy, and the Z osteotomy of his calcaneum was done not for a varus deformity, but he had a tuber which was still in varus afterwards. It's a rotation deformity, and it's just to derotate the tuber that we did the Z osteotomy again. The second case, the same age, a polytrauma patient, which at the right side had he had a cave varus deformity, but because of his polytrauma, he had a tibia fracture. Why he reduced itself is his tibia plafond. At the other side, he still had instability and pain. To chronic ankle instability, he had done a lateral brostrum procedure without correction, and he was still in pain. We did the same thing. We put him in the weight-bearing CT scan. We drawn our osteotomy. We made our guides. And this is the post-op result with a nice balanced painless joint. The last case that I show you is a male. He had the right ankle end-stage osteoarthritis, and he had total ankle prosthesis elsewhere done, but he was built in virus in his ankle prosthesis. And then you have a problem, because you have a stuffed joint which is really congruent. If you do an osteotomy, a classical one, you can have an impingement of your prosthesis. So we decided also to do the dome. We calculated our reference axis, and we made our guides. And I like to have especially this side, because if you do a derotation osteotomy, you can have hangover, so that can be a problem for the patient. So you can play with your osteotomy to have less hangover and to have better correction. Post-op use with a painless patient. So how do we do it? We make out the 100 scans that we did. We calculated reference points to the height of the osteotomy, but also the rotation of your malleoli and the center of rotation of your talus. We put it in a computer to make this nice science to correct your axis, and on this base we develop our guides. That we can do we plan the outcome and develop our guides. In surgery, it looks like this. So you do your osteotomy with a guide. You drill your holes. You do with a small scissor. You finish your cuts. You put your plate. You put your reduction guide, and then you can easily put your plate to fix it. We had a bone healing at 3 to 4, almost 4 months. We had in the 3 cases, we were 3 years out of surgery. We had no revision surgery. The only thing that we do, we remove our hardware, because probably if you have some arthrosis, it's probably not the end stage of the patient. So it's a dome osteotomy. We know it's a powerful correction osteotomy, but it's technically very challenging. And to make it more reproducible and to have predict outcome, we work with pre-operative planning on a weight-bearing CT scan and make our guides on a weight-bearing CT scan. Thank you.
Thank you very much. I think this is a beautiful presentation. It's totally the future with weight-bearing CT. Do you have time for one question, Chris, before you leave? Anyone has a question? It's now or never, or later. It's now or later, much later. Okay.
Don't you think you would have a use like from 3D prints? Don't you think in the future you could also think about of making these kinds of prints pre-operatively?
Well, we do it. We try to do it with the prints, but then again, you need some guides in. Actually, what happens if you go, you print your ankle out, and the guide is made on the printed. So you have in surgery, you have this model beside you with the guides on, and you take the guide off and you put it in the patient. So you have a 3D out printed ankle in the operating theater, which is sterile if you do the operation.
I think that's future.
There is an experience already in ITB osteotomy with 3D printing production of the guides. You have the 3D model, you can print out the exact guide to obtain the correct realignment. So it's all there. It's just a matter, to.
Yeah, this is a French company called Nuclip. But there might be other ones, and they are very advanced in high tibial osteotomies, and they've been demonstrating excellent results.
But the only thing is that because you can do it on a normal CT scan as well, but the fact that you have a weight-bearing CT scan and you have your bilateral views, you can correct the patient to the weight-bearing on the collateral side. It's not on. If you do it on a normal CT scan, you don't know what your foot is doing underneath it. Here you can have an impression. If you play with the images and you turn your foot, you can see what the first ray is doing. Actually, it's quite fun to see what's going on.
So thank you very much, Chris. And now handing over the microphone to the last speaker. So that's Arnie Bersens. He's currently a research fellow at University of Utah with Charles Salzman and Alex Barg. Alex Barg is the 5th member of the board of the Weight-Bearing CT International Study Group, and he's a big researcher, and unfortunately he wasn't able to join today.
Thank you very much, Francois, for the nice introduction, and also thank you very much for the audience for still being here and being interested. This is the last presentation of today. I'll try to keep it as short as possible, but I'm still happy to give the presentation because it fits nicely what was told before by Dr. Brutz with the 3D models, and also with the talk of Professor Demary promoting the 3D measurements in syndesmotic analysis. So when we're talking about measurement in syndesmotic instability, I think it was said before, we have a lot of methods. In the current 2D analysis, we have a lot of measurement methods described, and I think they are there because they want to overcome all the problems that we have, the manual measurements, the 2D measurements that we are currently facing. The worst of these are the plain radiographs, where you have the really the lowest specificity when you compare to all of the other measurements. They are a bit better when we're going to the conventional CTs, but what we're seeing here is these 30 methods described to perform your measurements. And that's a strange thing because you get a lot of angles and a lot of measurements, but you have only 6 kind of displacements in your syndesmotic lesions. You only have 3 rotations and 3 translations. So there's a really strange thing to perform all of these measures in your methods. But it's of course nice to see which one has the best reliability. But I think, as was promoted before, we have to go to these 3D measurements, and preferably with landmarks and as much automatic as possible. So to achieve this, we used the weight-bearing CT device in a patient cohort with subtle syndesmotic injuries, and also in a patient cohort with syndesmotic lesions in ankle fractures that were imaged by conventional CT. This was our study group. As was shown before, we had the high ankle sprains with subtle syndesmotic injuries and those having posterior syndesmotic fragment in ankle fractures. What we did was also a bit relying on the principle that was already explained by Dr. Brutz. We did segmentation to obtain the 3D models, and then we did easy understandable things. We used the healthy side to mirror it, as you can see here. And this healthy side was also a 3D model, and we used it as a template to actually fit it. And you can see here we use the tibias because they are large bones, and there are studies been performed on the fitting of the tibias from the 2 sides, and there's only 0.3 millimeters difference between those fittings. So that's really not a lot. And the fibulas are choosing to move along in their sprained position. And then you can see already here some small lateral diastasis of your high ankle sprain. But of course, we need further quantification of that. So we determined our coordinate system. As you can see here, this can be found back in a paper from Yamaguchi, where he clearly described this method of determining a coordinate system. We then determined our landmarks, and this was also something that we didn't do manually. We really used the software to determine this landmarks, and this is quite easily understandable, I think. We asked the software from this volume of the fibula, to compute the most inferior point, the most distal point, and every time I hit the button of the software, it gives me all the time the same point. So this is not anymore the situation where we choose the points with our mouse. We really can let the software identify them. The same here for the posterior tubercle, and the same here for the anterior. So these are really anatomical landmarks that can be computed, that you don't have to do manual anymore. So I think this is really an interesting application that can be used from this. We have then our coordinates from the 3 landmarks, and it's not shown here, but we also determine a shaft axis of the tibia. This is also computed, and we use these coordinates to put them in our MATLAB script, and out of this MATLAB script, our angles and deviations, or 3 translations, and our 3 rotations get determined, so we don't need more than that to describe our lesion and to know what is going on. And what is going on in these high angle sprains? So we mostly see external rotation of the fibula. We had a mean of 6.9 degrees, so this was a highly significant value. We saw some posterior sagging, so it's a bit of posterior translation of the fibula, but these were the main findings, of course, together with our diastasis. we did reliability analysis of this methods. It's not the same as doing before measurements and just doing some inter and intra-class correlation coefficients. It gets a bit complicated, but it's still comprehensive. It's the amount of deviation you get from the center point to the other points. So this, I think, we can still understand. The formula looks a bit complex, but it's still understandable, I think. So out of this, I think we can conclude that we have an effective method to compute and quantify our syndesmotic ankle lesion. It overcomes all of these measurement methods that are currently available on CT images, which are still, and that's a pity of using a CT for only do 2D analysis, because you have this volume data. So I think we can, with this method, really have this 3D description of the lesion. But I think one of the main limitation remains, and that will be in all of the studies currently, and that's why I think it's important, like already said by Professor Demiri, to perform this also in a cohort of patients without any syndesmotic lesions, to really have data on the normal values in 3D, and to have your cutoff values in determining which lesion is really pathological and which lesion still can be accepted without surgical treatment. And another limitation I think is quite important. We don't have any data on the ligamentous injuries, so we have our deplacement, but we don't know which ligament is injured. Of course, you can do an MRI on top of that, but it's of course interesting to know which kind of ligament causes which kind of displacement in the distal tibiofibular joint, and this can be really done easily in the lab. For example, here in the study that we're performing currently in Salt Lake with Professor Bark and Professor Salzman, where we do 4 conditions with no load, torque, and the 2 together, and we're looking at different kind of ligamentous injuries, and then you can see here, for example, in the actual plane, nice rotations coming out of this, and then we can attach it, of course, to which kind of ligament that is injured. Okay, I thank you very much for your attention and for being here. Thank you very much.
So thank you very much for your kind attention, and now we have some time. Actually, we have the room for the whole day, so I don't know what your plans are, but the speakers are here, except those who ran away. So if you have any questions, don't hesitate. So first we can have a session of questions now, and then we can all go and have some coffee together and just talk. So anyone has a question? That's one of the speakers, so the audience can also ask questions.
Actually, we don't need this, right? Do we need it? No. So my question about the syndesmotic. Oh, okay. I'm sorry. So for the syndesmotic injury, do you think it's possible to have a situation where the ligament is not completely ruptured, where it's just attenuated? Okay. The opening is not so large, but the displacement under load, in other words, the instability, is larger than in a case where, in other words, what I'm trying to point out that is maybe the syndesmotic injury may not be just the disruption that you see on weight-bearing CT, straight weight-bearing CT, but when you are actually applying some load that tries to open the syndesmosis, besides the axial load.
Yeah, I completely agree with that. That's a really good remark. And that's also what we're seeing now when we're doing this cadaver study, that it's not only loading, it's really also, and it's actually giving more displacement than just as a rotation, as a torque that we're seeing that is causing tremendous displacement when compared to the loading. So I think it would be interesting, as you're already working on this small devices to have in your cone beam CT, to really apply this kind of other stresses on your ankle joint to see this other types of it's completely is a good remark, and I think that's what we're seeing out of the cadaver study, and now it's again confirmed, I think, also by your study. So we should go through these and preferably standardize those, because we will have a wedge, you will, and then it will be 10 degrees, and then of course, so it will be interesting to have your thoughts on that.
Thank you. Can I commend on excellent work and commend everyone on the amazing infrastructure that you've created around standing CT. We've got a PhD student that's currently working on a project on dynamic scanning. So it's using a group that have expertise in looking at MRI scans for breathing. So when your lungs are breathing, your heart is moving, they're able to get static images from a dynamic function. And we're working on specifically looking at someone moving and loading within the scan and being able to try and get static images from that representation. And it just struck me that there's so much amazing work going on all around the world that one of the aims of the group should potentially be to coordinate that so that people don't reinvent the wheel, and that everyone knows what everyone else is going. So it'd be great to create some rooms almost where people can say, I'd like to participate in this research topic, and then you could get international collaboration, and the central hub would be the group, because I think otherwise everyone will be doing various different parts of work and only once a year or whatever presenting that work, when there's a lot of overlap actually.
I think Francois can comment on that.
So thank you for your comments on the infrastructure, and that's exactly what we are trying to build. The group has statutes, and it's going to be officially referenced somewhere, and we did our first academic meeting this morning with the board of the group and the academic affiliates representatives, which were Professor Ziegler and Professor Lierline. And this is typically to help us structure the research effort more and to give it a wider, more global scope, exactly to do that. Now, this is also something that I think should be known. It's of course available on our website, but the statutes are that the board is going to be a turnover in the board. So Martinus is going to step down. There's going to be a new president, and we need we're going to need after a few years some new blood. So any one of you is welcome to take part and to help us drive these projects. But definitely, everything is going more global. And we need to put all the data together from the whole world to come up with unique recommendations. And this was one of the first goals of our group. So thank you for raising that question.
One of the ways you could do that would be that you have a group doing a research project that pilots a research question and answer methodology, and then once you reach that critical mass, you've got proof of concept for your study, you then widen it up to the group for other people to contribute as part of it. So in other words, multi-centered contribution of data, and I think you can get some really powerful outputs.
Exactly. And Dr. Demary is going to help us write down a workflow, kind of a methodology, so that we can have a clear path to go from the data to powerful recommendations. So we need to build the structure first, and then we need to have people come in and help with their ideas, and then we'll be able to drive projects from the beginning to the end. Caesar, you want to?
Just a quick thing. I think it would be maybe a good idea after Dr. Demary give the contribution for us to kind of create a pathway. But I think maybe we could put in the website, maybe it's a good idea. For example, the line of research of each one of the groups. So, for example, you would be in the list of syndesmotic injuries and weight-bearing CT, and so people that are interested or to collaborate with that, they would know who to look for, because we are not, like, you're not doing everything at the same time. So now you're probably more focused on for example, the subtalar joint and the syndesmotic lesions. And so if Arne wants to contribute with you, he could check in our website and see who is working on what. And then I think that would be a great idea.
It will be the Weight-Bearing CT International Study Group ResearchGate. And it will be on the website. Yeah.
That's great. Yeah. So as you guys point out precisely, the whole effort, if we synergize and we coordinate well with regards to the hypothesis that we have, and data gathering and proofing or disproving our hypothesis using different database, I think it will be much faster and better validated implementation of this new technology. And just correct myself, this is not a model that I'm proposing. It's just a model that has been proposed over 2 decades in the Radiology Society by some of my mentors for any new imaging technique. This is just one small example. Every year when you go to RSNA, you see one new imaging modality that they're the vendors trying to propagate, say, better than the previous one. So there's layers of implementation of new technology. It starts from diagnostic accuracy, reliability, and then moving down in the list goes to the diagnostic impact. What does it mean? Means that the previous technology and the new technology. You give a questionnaire or some validated questionnaire to the surgeon without information of the new technology. What's the decision making? And without that, with new technology imaging data, what's now the decision? So that's called the diagnostic impact. And these are all methodologies that has to be followed on a religious basis. And then the therapeutic impact. Let's say you have a metric that's very diagnostically useful, but does it really change the management, or just it's good to know thing? So that's the next layer. And after all of that done, there will be a cost-effective analysis. Let's say it's great diagnostically, it's great for therapeutic decision making, but it's really expensive. So it really does worth like spending $200,000 to improve like one quality or one metric of quality of life for patients. So it's a long road. I'm telling you. I'm trying my best to at least make a more resolution, more concrete kind of a stepwise approach. We use examples of the flat foot and the syndesmosis, that there are two major foot ankle ones that we have done already in Baltimore area. And then anybody else who has brilliant idea can just jump on this, change it, modify it, and make it better. And hopefully you can help the group be more productive. Thank you very much.
Thank you. So does anyone else have a question for one of the speakers? Yes?
Yeah, so I was just wondering, how did you create those mathematical models?
There's a company in Finland that's called DCR, and they come from Nokia. Nokia used to be a huge developer of modern technology, and I think they had the biggest investment yearly in any European company for a long time. And they made a modeling program how to make telephones, and how to make like three-dimensional pictures of that with a huge resources. And this is just this technology now implanted changed to this field. So that technology do exist, but they are just implanting the mobile phone technology into the medicine and this in computer models.
No, but what I was wondering about is because this was specifically given on an example about this 40-year-old woman.
Yeah.
And so I assume that the mathematical model somehow represented her particular movement of bones, or was this just in general?
No.
Like model in general?
There were two models. Are you talking about the videos or the measurements?
So the video, like
the videos, okay.
Yes.
The videos, there were two different videos. One was just a mathematical model. The other one was the real bones, the real changes. And they were taking that way that we took the pre-operative CT and post-operative CT, and then we implanted it so that we thought that how the bones will move from the pre-operative situation to the post-operative. Okay, implemented. So I don't know the word in English, I'm sorry.
No worries. So this is your kind of interpretation of what you think the movement is going to be like, correct?
No, that's what the movement did happen.
Okay.
That's a real patient that was operated.
So could you repeat the name of the company again?
DCR. That's DCR? A real patient. That's okay, the same patient. This is the foot of the same patient. I know the patient well.
Yeah, I understood. Okay, thank you very much.
Yes. Yes. Yes.
Sorry. So it's the initial position, in other words, the pre and the post.
Yes.
So you have the starting position and the final position.
Yes.
But the interpolation in between, it's a mathematical interpolation.
Yes.
There is no images in between.
No.
Okay.
No.
Yes.
We have just.
Yeah, just to clarify that.
Yeah.
That's.
Yeah.
Yes.
Do you want to see it now?
I'm sorry?
Do you want to see it? The video.
So what do you need?
Just
this one?
Yeah.
You left the room when we were talking about your project. Do you want to just give everyone a just little summary, a very brief summary of what you're up to, just so they can...
All right. Hello, everybody. I am a PhD student from UCL. I'm collaborating with Curvebeam on a 4D dynamic CT of a foot and ankle. And the idea would be to be able to reconstruct the moving foot as it's being scanned in a CT scanner. So
I think you can use this because now I'm talking about two different companies. Planimed, that exists here, they make these CTs, and DCR is another company, but they can do the model from any. You just need the DICOM files, so they can do it from any other machine or whatever.
Yeah. So the reason I was curious about this is because I understand that if you have the DICOM file, then you'll have you can get the segmented bones and so on. But I was just wondering, how did you get the motion?
You have to ask them.
Yeah.
It's a very complicated technology that's been implanted here. That's been developed by hundreds of people in the time, and I think they're better. I'm just a surgeon. But I'll be happy to take you there if you want, and introduce you afterwards. So if you want to join me, I think Andy will come with me.
Sure. Thanks.
May I try to?
But just to let you know, I don't work for the companies.
Yeah,
I've never received a single penny from them. I'm just doing this for hobby.
To support the comprehension of the discussion, when you talk to biomechanists about a mathematical model, about an anatomy, you refer implicitly to a bone model which is not taken from a patient, but which is a sort of average among similar foot. So it is not specifically representing one subject, but it claimed to represent all subjects. And because it is parameterized, you can then deform according to the specific data collection, and having something which is very similar to your single subject, but taken from a mathematical model. Okay, so that is something which sounds
This is pretty much a mathematical model that's been done by a foot.
Yeah.
And this one was a real patient.
Okay, because with mathematics you can do everything, but implicitly in our mind, when you say mathematical model of a mathematical model of a bone, it is something which is an average representation. What I've understood talking with this guy is that basically they have a model of the situation before and after surgery. They, of course, brilliantly match what it is a reference for this bone, so you can see the effect of the treatment, particularly if it is a surgical correction, by looking at the two positions. And if you take a sort of interpolation of the two conditions, you can get sort of animation of what has been your treatment. This is
just to clarify. Yeah. So what's happening here is you're making assumptions on the motion that's happening.
Exactly.
Yeah. So when the foot plant flexor and dorsiflex, the fibula moves relative to the tibia. We know that. But in this model, it doesn't, because they haven't built that in. You have to add in the assumptions. So this isn't an accurate representation of exactly what's happening, but it's about trying to assume what's happening, and it's really difficult. So, for example, on this one here, you can see the motion they built in is at the first TMT joint, which are there, but you're not seeing motion at this joint, which will be happening as well. It's a composite motion of the whole of the midfoot. And it would be fabulous if we could do this in real time,
on real stuff,
on real motion, showing all the composite motions.
You can do that if you have taken sections during the motion. Like, in other words, if you take some sections during motion, then you can do it.
That's what the 4D.
Yes. So that's where the 4D is. But this is just like the beginning and end, and you just simply interpolate in some way.
Here is actually two videos, to be honest. Two different videos.
2D in that, yeah. It's only one
you
direction.
See, there is one when we have locked the talus, and all the bones move around the talus. And the other one video, you see we have locked the tibia here.
Yes.
And then you see the movements of the lower joint. So when you have to show the movement, you have to lock one of the bones. You see see how the other bones move and changing around it. So that's why it looks like, but if you look at it carefully, you will see which one we are using there. So now you see the tibia is not moving at all. You see the bones are moving, and we wait now. Now we have locked the talus, and now we see the changes of the pre and post-operative. Well, we just know that, of course, the end results of the video, the start and the beginning are facts. Everything else is the mathematical model.
Oliver, do you know? So we all understand that this is the beginning and the end point, before and after, and what happens in between is the interpretation of the one that's creating this video. Okay, so it was the movement kind of just created out of nothing, or assumptions, or was it created using like the direction of the joints, some information from the model?
I assume so. Yeah. Ask more. It's so complicated. The technology around this. As I told you, I'm more a simple surgeon. Just ask them. Ask the company how we have. I'm sure they will provide you with the exact information how they did it, because it's not. They don't just draw a line. They also have the movements thought in the model, that they don't just put two lines and put the bone going like this. They have implemented a model that calculates as assumed.
There is also something that should be mentioned, is that this is a nicely, completely segmented foot. So it's only possible because we have this. But prior to this stage and being able to produce these videos, you have to segment the bones. And currently it's only possible if there's no hardware and if there's no arthritis, because if two bones are touching, the computer doesn't know how to. But they are also making lots of progress on this side of thing. But it's...
I don't know about the joints, but for example, the other company, PlanMeca, they have a program that they can take the hard metal away. So they can take the effects of the hard metal quite well away, so you can do that afterwards. Even if you have to dig, this has the hard metal. They've been treated with the material. There are 2 screws in the planter. If you go to the stand, there is a three-dimensional prints of the same foot. I'm sorry, I broke them on the way.
It's okay.
So you will only see, but if you look at the here. So here, if you go and see the models pre-operative and post-operative, you will see the screws there.
Okay.
There are, if I remember right, there's 2 screws going from the heel. Then there is a plate also here, because in this foot there was done lateral column Nathan, medial column MCO, also a cotton and a chevron and Aki.
Right.
And all the hardware is away from there. Also from the CTs. I have the CTs here if you want to see them.
Okay.
From the patient. And the full CT.
So, anyone else has any questions? Yeah. Otherwise, we can just go towards the coffee machine.